Our final speaker today is Joan Alker, Executive Director, Research Professor at the Georgetown University Center for Children and Families. She's a national expert and frequent commentator on the impact of changes to Medicaid on low-income families and children, particularly the impact of the waivers. And we're so honored she's here with us today to share her perspective on the future of waivers under the new administration.
Thanks so much, Catherine, and great to hear all these interesting presentations. I thought I would just make a few observations on kind of where we see things going, and also I think some of the lessons learned from all that you've heard today. First of all, certainly, as Mary Beth indicated at the end of her presentation, there are very big questions on the table for Medicaid today. The ACA repeal, of course, would include a repeal of the Medicaid expansion potentially, which does finance both of the Indiana and Michigan programs. So that's obviously a fundamental question right there if the money is going away. And, of course, there are plenty of reasons to think that Congress will move to block grant or cap Medicaid spending. So all of these issues are very, very consequential. But I think one thing we can say for sure is that we will see waiver activity. We will see a fair amount of waiver activity going forward. We always do see that in the Medicaid program. And frankly, for administrations of both parties when they come in, their waiver policy is really typically a prominent feature of their Medicaid policy. In part because legislative changes to Medicaid are pretty tough, and I think we're going to see that this year. And especially when the legislative side gets tougher, we see administrations and states looking to waivers. I do think it's important to mention, and I think the presentation from Anthem really underscored this, that there are plenty of things that states can be doing in the managed care context that don't even require a waiver. There's a lot of mythology about waivers and state flexibility in the Medicaid program because states already do have a lot of flexibility. So where you see the need for a waiver arise is essentially for two reasons. One is a permission to waive certain federal requirements or to either get some additional federal funds or use federal funds in ways that are perhaps not generally sanctioned by the Medicaid program. But on the issue in particular of healthy behaviors and incentives, there are ways in which plans could be working on that with the state that really wouldn't require a waiver. So having said that, I want to make a couple of more observations and, again, to just underscore, I guess, from sort of a step-back perspective that, unfortunately, sometimes some of these issues can be not very policy-driven, but perhaps ideologically driven and resulting from some of the struggles and fights over Medicaid expansion. And that it's important for policymakers and others when they're thinking about approaching this issue of incentivizing behavior, which we know is a very difficult question in any context across the healthcare system. Changing behavior is a very hard thing to do, is to really get some clarity on why this is. Is this a cost-driven undertaking? Is it an undertaking really kind of a desire to promote personal responsibility? What is the goal? And so I would say, for example, that if it is really a cost-driven initiative, that there may be ways to think about that, focusing on certain high-cost populations, intervening there, rather than very broad programs, which I think, as Mary Beth outlined, the kinds of approaches that we've seen in Indiana and Michigan can be very, very complicated. And that complexity, I think, really raises issues and challenges for initiatives that are really dependent on this sort of rational choice model, this assumption that folks will make good choices because they have all of the information they need to make that choice. And because these are very complex initiatives, because both the providers have to understand them, the consumers have to understand them, and in fact, when they're linked to premiums, the eligibility workers and the enrollment system has to understand them. I think, as we know from the Kaiser study, that it's just likely not happening on the ground. And I think that's something very important to keep an eye on as we see more evaluations coming out about these two approaches, also approaches, for example, in Iowa, which has some similarities. So that's a real challenge. There are administrative costs, too, associated with these kinds of complex initiatives. So I think it's very important to get very clear and precise about what the goal is and design some targeted interventions. And again, that doesn't necessarily have to be through a waiver. So with that, I think I'm going to wrap up, Catherine, and hand back to you so you can have a few minutes for questions and closing.